छाया है किसी की जान जाती है किसी को शर्म
And Madam needs no introduction, but just to complete.
Hello, Charmila, after a long time.
Yes.
Yes, good to see you. Nice.
How are you? You're fine?
सबसे अच्छा कौन सा है हमारा? इंटरनेट सबसे अच्छा कौन सा है? नेट सबसे अच्छा कौन सा है हमारा?
Ladies and gentlemen, we welcome you to this evening's session of the research methodology. This is the second session. We had a very good start last Saturday where we had Dr. Sendil Rajappa address us. So we have 3 talks this evening from 5 to 6 p.m. We have 2 esteemed chairpersons. I take great pleasure in introducing Dr. Bhagyalakshmi Kakkar, Bhagyalakshmi Naik, who is the Associate Professor, Department of Gynae Oncology from Cuttack. She is the Chairperson of the Oncology Committee of FOGSI and the Vice President of AOGIN India. The second chairperson for this evening session will be Dr. Rupinder Sekon, who is the Chief of Gynae Oncology at the Rajiv Gandhi Cancer Institute and Research Center, New Delhi, and the Treasurer of our organization, AOGIN India. So I will hand over the session to our chairpersons. Dr. Bhagya?
Yes, I'm not able to see Dr. Rupinder, so that's why I'm hunting. Has she not joined yet?
I think we can go ahead, Bhagya.
Okay then. So I again welcome you all on behalf of AOGIN to this very wonderful and very academic session, which has been the brainchild of Dr. Lata. So I think you all will enjoy. So our first speaker is Dr. Kanu Patra. Can I have his CV? Can you show it? So he is a leading radiation oncologist heading the Department of Radiation Oncology in Vizag Mahatma Gandhi Cancer Institute. He has many publications and has been invited to give many lectures. And the best part is that he was a postgraduate in the same institute where I still work now, and Kanu was a very bright student. So I think Kanu, without much ado, let's go ahead. And he's a very good clinician and a researcher as well. So thank you.
Ma'am, good evening. Patro here.
Yes.
Am I audible?
Very much, yes.
Okay, so shall we wait or people are still joining?
No, we are already 70. I think we can start off.
Okay.
We already have 70 people, so I think we can start, Kanu.
Okay. So thank you, the organizing event. Okay. So my topic is relative risk and odds ratio, and I'm going to tell about this within 20 minutes. Hope I will complete and win your heart. So before anything, I am not a statistician, but I know that what we should know. So before I start, I will ask a sorry note to all mother-in-laws in the audience and all would-be mother-in-laws in future. So there are 2 things. One is the exposure, another outcome. Am I audible clearly? Okay. Exposure, another is outcome. So what is causation? It indicates that one event is the result of the occurrence of other event. That is, there is a causal relationship between 2 events. This is also referred to as a cause and effect. So what is the measure of association? A measure of association that quantifies the relationship between exposure and disease among the 2 groups. It either may be positive association or either may be negative association. So what are the examples of outcome measurement? Maybe risk ratio, that is called relative risk, rate ratio, odds ratio, proportional mortality ratio, and many more. There are more ratios, more proportions, more rates, all things are there. But we are not going to discuss all those things. What is the ratio, what is the proportion, and what is the rate? Ratio means just ratio of 2 things. Proportion is the numerator is included in the denominator. So always say denominator is more than numerator. Rate is a proportion of the relative to the time. So in this outcome exposure and outcome measurement, definitely there is, we have to go for the contingency table, where in the it is called contingency 2x2 table. One is exposed group, another is unexposed group, and this is the total cases and controls. So if cases, if you are exposed group, these are the cases, these are the controls. The total population will be A plus B. Unexposed group C, cases will be C, controls will be D, and the total will be C plus D. And here total population is A plus B plus C plus D. So in my topic, I will discuss about the odds ratio, relative risk, and correlation. So there are two types of study. If you see in the literature, there are two. One is the observational study, another is the interventional study. In observation, you see the observation, you no need to intervene at all. You just follow the giving a some drug or something or some outcome. You observe. Interventional study, when you are giving an intervention either from a drug or something of the treatment. So you have to calculate from the or relative risk or odds ratio. If you see the relative risk, the risk of event in treatment group by risk of event in the control group. So if you see A by A plus B, so A by A plus B. In odds ratio, it is A by B, not A plus B. So you see the denominator. A1 in a risk ratio, it is A by B, A plus B, and in the odds ratio, the only is the B. So if you see A by A plus B here, if you see the contingency table here, the treatment arm and control arm, the events and no events, if you see A is A by A plus B and A by B. So this is the only difference is the denominator. So if you see the number of events by all outcomes, all events plus no events, same thing in odds ratio. So that is a number of events by number of no events. So the only difference is the denominator. Nothing much difference. Only in the difference is the denominator. So what is the risk and what is the odd? See, this is the slippery area is the risk. Odd is the falling down. Like that, the risk is the knife, and you get the odd is the injury. Like that, accident is the risk, and getting injured is the odd. So like that, marriage is a risk and fighting is a odd. So there was a person called Null, and there is an alternate. So they invited the risk. They started dating here. This is the risk. They accepted the risk, and this is the causative factor. Mother-in-law came to the in between them. So this is the odd. The fighting started here. So after the fighting started, so what is relative risk? Then when the relative causes the risk. So who is the causative factor? The causative factor is the mother-in-law. I am giving a good example here. The causative factor is mother-in-law. So the person gone back and find out this mother-in-law what is a toxic mother-in-law. So this mother-in-law he handled, it become monster-in-law. So I am giving a very simple example. See, then after fighting with all, then they went to the counselor. After discussing the counselor they explained and given two examples. He has a one bad news and one has a good news. What is the bad news? So if you see the relative risk, incidence of outcome in exposed cohort by incidence of in unexposed cohort. So how to interpret the relative risk? So if the risk is 1, relative risk is 1, there is no association. If relative risk is more than 1, positive association, and there is a increased risk. There is an increased risk. And if risk ratio is less than 1, suggests negative association and decreased risk. So when there is a fighting incidence, when mother-in-law is a exposure. So if you see the fighting incidents, the bad news given by the counselor, if you see the fighting incidents when the mother-in-law is an exposure, if mother-in-law is there involved, the fighting incidences is at 45 with no fighting. If there is a mother-in-law is not an exposure, the fighting incidence at 10 and no fighting is 90. So total population is here is 100. And if you calculate the risk ratio or relative risk, so you see the denominator here. This is the 100. Both no fighting and fighting population it is the 100. And if you calculate the risk, relative risk, it is a 4.5. So in this study, persons who being mother-in-law is a relative, there is a 4.5 times of higher the risk of fighting between the couples. So this is the bad news given by the counselor. Now the good news is that when fighting incidences, when you follow the mother-in-law's advice, so if if you follow the mother-in-law's advice, the fighting incidences are less, but no fightings are 20. Like that, if you don't follow the mother-in-law's advice, the fighting incidences are more and no fighting is less. So if you calculate this relative risk here, the relative risk came as a 0.4. That means in this study, persons who regularly following the mother-in-law's advice, there is a 0.4 times the risk of fighting between couples compared to the who does not follow. Means there is a 60% decrease in the fighting, and that was a good news given by the counselor. So how to explain to the relative risk? As a relative risk, as a percentage increase or decrease, or as a number of the time increase or the decrease. So relative risk 1.37 means, suppose it is 1.37 means the risk of disease increased by 1.37 times. And or you can explain in percentage ways. 1 minus relative risk is into 100 is equal to 37%. So risk of disease increased by 37%, or risk of disease increased by 1.37 times. Like that, if relative risk is 0.8 means risk of disease decreased by 20%. So what you will do, you have to minus from 1, and there is a 0.8, 1 minus 0.8 is equal to 20, 0.2 times. So disease is less by 20% or 0.2 times. Relative risk 3.37 means, again I am giving an example, 3.37 times means 1 minus RR into 100 is risk is increased by 237%. So hope you understand how to explain the relative risk. Now, whether what is the percentage of increase or times of increase, there is no problem, but you have to see the p-value as well as the confidence interval. If the p-value is 0.05, more than 0.05, or confidence interval that includes the 1, our relative risk is not statistically significant, no matter how is the large or small relative risk. If you there is a 37% or 100% increase also, but if your p-value is more than 0.05 or confidence interval includes the 1, there is no association or association by chance. Like that, if there is a, suppose there is a, if you do a laparotomy, have an accidental appendectomy, the relative risk is wound infection is 4.2, means there is a 4.2 times of chances of increase times of risk of post-operative wound infection if there is a accidental appendectomy. Like that, if you see the aspirin and myocardial infarction, there is a if by taking the aspirin, if you put in the contingency table, those are getting infarction and that is not getting infarction, the risk ratio is 0.58. 0.858 times of risk myocardial infection means there is a, you have to minus from 1, there is a 0.42 reduction in comparing to the those are not taking the aspirin. Like that, if you come to the odds ratio is exposure in those with disease and odds of exposure in those without disease. So if you see the same incidence by fighting incidence with mother-in-law is an exposure, if you here the denominator is not included in the no fighting population, so it is a 45 by 55. Like that, 10 by 90, it is not, although if you see the denominator, it is not 100, it is 55 and 90. So if you calculate, there is in this study, persons who is having mother-in-law as a relative, there is a 7.4 times, 45 times of 45 times of odds of fighting between the couples. Like that, if you follow the mother-in-law's advice, there is a decreasing incidence of fighting 0.2 is equal, means there is 80% decrease in the fighting when you follow the mother-in-law's advice. So how to interpreting the odds ratio? Same thing like relative risk. So there is no change in frequency of exposure if there is 1, odds ratio is 1, If there is odds ratio is more than 1, increased change of frequency of exposure. If there is odds ratio is less than 1, there is a decreased chance change in the frequency of exposure. So suppose if you can go for more examples, if odds ratio is 1.2 times means 20% increase, 2 means 100% increase, 0.5 means risk is cutting to half. So like that, how strong is the association? Again, you have to go see for the p-value, and again you have to see for the confidence interval. If p-value is more than 0.05 and confidence interval is more than 1, it includes 1, OR is not a statistically significant, no matter how is the large or small odds ratio. So I will tell you how it is the formula. You see the denominator. Again, I am telling to see the denominator. A plus B, here the only B. So in here, the denominator contains numerator. Here, numerator is not, denominator never not containing denominator in odds ratio. So if you see the relative risk and odds ratio, A by A plus B and A by B. If it A is 1 and odds relative risk is 0.33, odds ratio is 0.5. But if you slight increase A value, the relative risk is 0.49, but odds ratio is more than 1, it is 2.5. So it is not a correlation. So the slight increase in the relative risk, odds ratio is more. Slight decrease in the numerator, odds ratio will be more. So it is overestimates your risk comparing to the relative risk. So odds ratio overestimates the risk. So suppose a patient who takes the regularly some type of food and gets cancer and not getting cancer, out of 100 population, 80 people get cancer, 20 people not getting cancer, the relative risk is 4. But if you see the odds ratio calculation, it is 16. So here odds ratio overestimates the risk like that. But in rare outcomes, if you see rare outcomes means 5 by 1000 get cancer versus 2.5 out of 1000 non-users getting cancer. If odds relative risk is 2 and OR also 2. So in rare outcomes, the relative risk is equal to odds ratio. In it is not good for if there is a outcome is more. Again, I will give an example. I will give a very simple example here. If you see, that is a interventional control arm in this left side, and this is the odds ratio calculation. This is the relative risk calculation. And if you see here, the death rates are same, and see the odds ratio is 1 here, relative risk is 1 here. Deaths are increasing, so deaths are decreasing, and there is a difference between odds ratio and intervention and control arm. So slightly there is a difference. If you see the last line, last row, if you see the intervention arm death rates are 45, control arm is 10. Then if you see the odds ratio is 7.45 here, it is 4.5 in the relative risk.
Unmute my
relative risk calculation. So if you see here, odds ratio overestimates the risk. Same thing, it is 4.5 here, relative risk, odds ratio is 7.45. So if you see the death rates are slowly increasing here, odds ratio overestimate the risk. So what is the difference? Then why there are two differences? When we should use odds ratio, when there is use the relative risk? The basic difference is the denominator. So there is a basic principle when there is a less than rare outcomes and the incidence is prevalence is the less than 10%, odds ratio is equal to relative risk. If the rarer the disease, closer the approximation. But if there is a big difference, big outcome exposure and more exposures, definitely there will be a difference. So odds ratio versus odds ratio and relative risk. Relative risk is needs incidence of disease. Odds, I think there is some background audience, background disturbance. You can ask your host to mute all. So there is a relative risk and odds ratio. The relative risk is needs the incidence of the disease. Odds ratio, it is not incidence calculation. Mostly relative risk is used for the prospective calculation and odds ratio is for the retrospective calculation. Mostly demonstrate temporal distribution, but odds ratio mostly case control studies, and relative risk is the cohort studies. Let's see once. So there are two types of studies as explained before. Retrospective is case control and cohort. Prospective is the cohort study. In this case control study, you are going backward. You see the outcome and find out the cause. So this is the case control study. You are seeing the outcome, you are going back, you see the past. But in cohort study, you are seeing the exposed and non-exposed population, and you are giving a some drug or some some patient is taking drug. Some people you are smoking and you are not giving it. That is not interventional arm. So if you are giving a patient, you are evaluating for smoking and lung cancer or anything. If you see, it is a prospective study. You are seeing the future. You are looking for the outcomes in the cohort study. So this is the cohort study. It is a forward study or prospective study. You are giving exposed. There are two populations, exposed and non-exposed, and the two outcomes, positive outcome, negative outcome. But in case control study, all populations are exposed. There are two outcomes, diseased and non-diseased, but all population is exposed to particular thing. So if, suppose case control study, an example, food poisoning. If patient has in a restaurant after eating the food, there is a poisoning, you are finding the association. Is there any salad or rice is getting putting the food poisoning? If you see, all population has got exposed. So it is a retrospective study. All population are exposed. So it is here we calculate the odds ratio. But in cohort study, smoking and lung cancer, you are dividing the population is a exposure and non-exposure. You are going a prospective study, and here all populations are under your observation. Then it is called a relative risk. So in cohort study, if you go, all people are exposed. In a cohort study, some people exposed and some people are not exposed. So even when you are going for cohort study, you calculate relative risk. When you are going for case control study, you have to calculate the odds ratio. In summary, case control study and control cohort study, it is a retrospective, it is a prospective, comparing diseased groups versus non-diseased group, compares exposure group, non-exposure group. This is very important. Looking for exposure to risk factors, asking the exposure change in the likelihood of disease. You have to calculate the odds ratio in case control study. You have to calculate the relative risk in the cohort study. So in summary, odds ratio and relative risk are often confused despite being a unique concept. The basic difference is that odds ratio is the ratio of odds, but relative risk is the ratio of incidences. In case control study, you conduct odds ratio. In cohort studies, you calculate the relative risk. But if there is a rare outcome after some exposure or less than 10%, relative risk is equal to odds ratio. So coming to our story, when the person followed the mother-in-law in excess, and then is the relative becomes odd. So when there is a more outcomes, the all relatives odds ratio overestimates the relative risk. So in conclusion, please follow in loss, otherwise you will be in loss. Thank you very much. And if you are more interested in the funny statistics for the doctors, please go for this link. I have many 100 slides for the with many cartoons and many concepts. You can download here and you can utilize before your exam. Thank you very much for your for the organizers and AYGN for the giving the opportunity.
Thank you very much, Kanu. I think people must have really enjoyed your talk. So I can't really see much questions in the chat box. Lata?
Yeah, I think there is just one, which
Okay.
says, the question to the speaker is, can you please explain again how odds ratio overestimates the risk?
Okay, so I'm going to bake, madam. So you see this table. It is a very good table. You can see the odds ratio overestimates the relative risk. So if you see the death rates, here the death rates are similar in intervention arm and control arm. If you see these death rates, if you calculate put the formula A by B and all things, you can see the odds ratio is 1 and relative risk is the 1. When there is a rare event or very minimal event, the odds ratio and relative risk are same. Suppose intervention is it is a rare event 1 and control arm is 10 deaths. If you see here also it looks similar odds ratio and relative risk. Suppose come to the interventional arm of the fifth row. If you see the fifth row, the death rates are more in the interventional arm and control arm is 10. If you calculate the odds ratio here, it is a 7.45. But here relative risk it is a 4.5. So if you see here odds ratio overestimated the risk. So this is how odds ratio overestimate the relative risk.
And there's one more question. Why would one need to know the incidence of a disease for relative risk calculation, but not for the odds ratio calculation?
So if you see, the basic formula for the relative risk is the denominator, A by A plus B, because even you are mostly the cohort studies, if you see the you are taking a cohort population, suppose you are 100 population, 90% are using the smoking, doing smoking, 10 people are not smoking. So relative risk is the denominator. Denominator is both A plus B, means all people in the population what you are doing the observation is in the your formula. So the relative risk the needs the incidence. Incidence means in a particular population you are seeing the how much exposure, how much the outcome. Any more questions?
So I think thank you so much, Kanu. So we have our next chairperson, Dr. Rupinder. So we'll go ahead with the next talk. Thank you so much for the nice illustrative talk and making it so interesting with mother-in-law story.
So I am feeling sorry for all mother-in-laws and but there is a good news and both bad news also.
Thank you so much.
Okay, good evening everyone. Our next speaker is Dr.Sajjal Kakkar. Am I audible?
Yes.
Okay. Next speaker is Dr. Sajjal Kakkar. He is the Principal Consultant, Radiation and Clinical Oncology, Max Hospital, Mohali. He's trained at TMH Mumbai and also at the University of Michigan in the US and Institute Gustave Roussy, Paris, France. Is he there with us? Dr. Sajjal, are you there?
Yes, Sajjal is very much here.
Yes, ma'am.
That's great. So he was formerly an assistant professor and head of radiation oncology at HIHT University in Dehradun and also a consultant at Apollo Hyderabad. He's published several papers in national and international journals. So we are looking forward to Dr. Sajjal Kakkar's talk on survival curves. Isn't that what you?
I think on forest meta-analysis.
Forest plot in meta-analysis.
Good evening,
Yeah, that's just as well.
Very good evening to all of you. At the outset, I would like to thank AOGIN India Chapter India Academics for this opportunity. I hope I am audible to everybody.
Yes, if you can just speak closer to the mic, it would be a little more clear.
Okay, so it's really a pleasure to be part of this August gathering where all the experts as well as the students are there in attendance. And it's also very heartening to see that people are interested in the biostatistics because now most of the time it's a neglected topic, especially in our curriculums also. And we always tend to go to the conclusion of a trial rather than understanding how it was done and what are the nitty-gritties involved. So the task given to me is to describe in detail the forest plot. I know everybody, most of us know what is forest plot. I will try to refresh your knowledge and try to walk you through about the forest plot and its elements, and we'll try to make things in a simplified manner in next 15 to 20 minutes. Now, forest plot is an important part of a meta-analysis. So what is meta-analysis? Meta-analysis basically is a statistical synthesis. It's a statistical tool basically. It's a statistical synthesis of the data from different clinical studies which have comparable effect or comparable observation. And why we need a meta-analysis? Sometimes there are trials which are smaller in numbers, which have which are underpowered and can't give us answers. Now there are trials trying to answer the question, but they have conflicting. So there, when we combine all the trials together and do the analysis of the analysis, that is meta-analysis, we may get a clearer picture. Meta-analysis also helps us to get a reliable information, a more precise information, because we only generate the develop the hypothesis and we test the hypothesis. The subjectivity in the analysis is removed obviously when you are doing meta-analysis. It also takes care of what is called file drawer effect. Basically, it removes the publication bias, because sometimes the negative results are not published. So this publication bias also is removed if we are doing a meta-analysis. Meta-analysis has lot of steps, but what we are concerned is basically analysis of the data. And analysis of data needs the measurement of effect, which Dr. Kanu has explained very nicely. So I'm not going to go into the details about relative risk, odds ratio, or the hazard ratio. But what is more important is the interpretation of the RR and OR. As Kanu has already told you, if relative risk or risk ratio or odds ratio is more than 1, that means there is increased likelihood of the outcome in the treatment group. If it is less than 1, then there is decreased likelihood of the outcome in the treatment group. And mind you, outcome can be positive as well as negative. And if RR or OR is equal to 1, that means there is no difference in the outcome between the treatment and the control group. This OR and RR should be accompanied by confidence interval. This is very important. Just few seconds on confidence interval. A confidence interval basically are the numbers, or it's a range of potential values where the true value lies. And what do you mean by 95% or 90 or 99%? Basically, it is the confidence level. That is, we are 95% confidence. If we repeat the same test again, our results will lie in the range which is given, and we are 95% sure about it. A more important thing about confidence interval is the width of the confidence interval. This indicates the precision of the estimate. Now, wider the interval means lesser is the precision, and this is very important in forest plot. I will show you in the coming slides. If confidence interval includes 1 or it touches the 1 or line of null effect, that means the results are not statistically significant. Confidence interval doesn't include 1, so that means the statistical significance is there. Now, just to illustrate what I was talking to you, if you see in this diagram, this horizontal line is basically line of null effect or line of no effect. And what you see 4 vertical lines here are, these are the 4 different studies. Now, if you see the study in the extreme left, now here if you see this width, this basically is the confidence interval. So here what we see, the results are statistically significant because they are above the line of null effect, but the precision is low because confidence intervals are wide. Okay, if you see the B, the second study, it is still statistically significant and confidence intervals are very narrow here. You see the width of the confidence interval, it's quite narrow. That means the precision is high. See, there is difference between precision and accuracy. So what is the precision? Precision basically, if you repeat the test again and again, you will get the values very close to each other if your confidence interval is narrow. Okay, and if your confidence interval is wide, then the results may spread out. So that is basically the meaning of the precision. If you see the study C, it's not statistically significant as it is crossing the line of null effect, and the precision is also low because the confidence intervals are wide enough. The fourth study, the D, it's not statistically significant, but confidence intervals are very narrow, so the precision of the study is high. Okay, I hope this concept of CI is clear to all of you. Now, coming to the forest plot, basically forest plot is a graph which displays the results of a meta-analysis. It's basically a jungle or a forest of lines, vertical and horizontal lines. Okay, the first forest plot was given by Freeman et al. In 70s, but it was not a part of a meta-analysis, and it has no overall pooled estimate given. Only it showed the results of the individual studies. The first forest plot as a part of meta-analysis was published by Louis et al. In 1982, where they gave the overall estimate, the results also at the end of the forest plot. So this was one of the first forest plots which were published in the literature. Forest plot, sometimes it's misspelled as forest with double R because it is thought that the forest plot was first described by a researcher whose surname was Forest. He was a breast cancer researcher. So sometimes you may see the spelling as forest with a double R also. Now coming to the forest plot now. Now when you see this chart, sometimes we are frightened. Whenever we open a meta-analysis, it's very frightening to see such kind of numbers and charts here. And it's always we tend to go and see our conclusion. Let's see the conclusion whether there is benefit or not. Why to read this, or who will read this chart? But I will try to make this chart simplified to you. This basically is the forest plot. Now what you can see here is the forest plot. There is a group of lines, horizontal and vertical. So this is the forest plot. In the coming slides, I will basically dismantle the entire plot and will reassemble the plot one by one to make it easier to understand, or I'll try to simplify it. But the most important thing in the forest plot first is the axis. Okay, you can see the axis here. Now there are horizontal axis. This is the one, and then we have a vertical axis. So let's see the axis first. So what is horizontal axis? Horizontal axis basically refers to the statistic which a trial is showing us. As Kanu told, OR, RR, or hazard ratio. So basically the horizontal line is the first thing which we should see when we are looking at a forest plot. It tells us a statistic which is being showed in the meta-analysis. So this is the horizontal axis. Then comes the vertical axis. Now this vertical axis is the line of null effect. As I again discussed, this line of null effect is very important. If a outcome is lying on either side of line of null effect without touching it, that means it is statistically significant. So these are the axes of a forest plot, which we should all be first looking at the axis, and then let's go and see the horizontal lines. Must have seen lines with squares and rectangles. These are also known as lozenges with wings appear, and this is also known as blobs. Hence, forest plot also called blobogram. So let's see what these funny shapes mean to us. So we have this axis. I hope I am audible still to everybody.
Yeah, yes, definitely.
Yeah. Okay. Yeah. So this is the axis we have seen. Now, if we are lying on the left side, that favors the treatment. If we are lying on the right side, that favors the control. And this is always written there if you see the axis very carefully. Sorry. Now these are the, now what are these? This lozenges and wings, what I was talking about, this represent the studies. So we have 3 clinical studies here which are being analyzed. Okay. Now these studies has 2 parts. One is the square. Now this square represents the point estimate, that is the relative risk ratio or odds ratio. Whatever the studies, the trial is showing us, the center of this square represents the, gives us the point estimate. You can just drop a perpendicular down to the axis and you can get the RR or OR, whatever this trial is showing of that particular study. Okay. Now the size of this square or rectangle represents the weight of the trial. Now what is weight of the trial? Weight of the trial means the power of the study or the number of participants of the study. Wider this square, more is the weight. That means the study has more number of participants, and more the participants, obviously more is the statistical power of the study. And what are these wings? These wings basically are the confidence interval. So I have already told you about the confidence interval. Wider the confidence interval, less is the precision. Narrow confidence interval, higher the precision of the study. So this gives us 95% confidence interval. These horizontal lines, basically what we call as wings, basically represents the horizontal confidence interval of the study. Now we have, suppose we have 2 more studies. We have combined all the 5 studies. Now what is the combined result? Combined result is given by diamond. So diamond of the bunch gives us the combined result. Diamond again has 2 important points. I will show you in the next slide. The center of the diamond gives us the point estimate of the combined all the studies together. So if you drop a perpendicular to the these like this, the midpoint represents the overall estimate of all the studies taken together. And these edges represents the confidence interval of the diamond. So diamond also has confidence interval. The edges represents the confidence interval of this diamond. Okay. So coming upon to this meta-analysis, once again, let's see one by one what this chart tells us. Okay. So first column, the first column mostly tells us about the name of the study or author's name, publication year, or the journal name it will tell us. Next is basically number of events which has happened in both arms, that is the intervention as well as the control arm, number of events divided by the total number of patients in the same. So this is given the second column. Third column usually is the observed minus the expected events, which helps us to calculate the variance. This is another statistical tool, but I'm not going into the detail of what variance is. Coming to the extreme right portion of a this plot. The extreme right portion of the plot tells us, gives us the forest plot in numbers. So whatever we see here in the forest plot graph is given in number in the extreme right corner. Okay. So whatever these studies, the diamond effect, the point estimate has come, it is given here. So this is basically hazard ratio, it is given here. So extreme right corner gives us forest plot in the numbers. So next is the diamond. I have already showed you the last row basically gives us the statistics of the diamond. Okay, you can see here, this is the point estimate. This is the confidence interval given. Then comes the left. Now the extreme left corner is again very, very important as far as the meta-analysis is concerned. It gives us heterogeneity. Now what is heterogeneity? We will see. Now all the trials, though they are trying to answer a similar question, the results are never same. Their results are different. Now why this variation comes in the trial? This variation has come because there are several factors. It can be related to patients, inclusion or exclusion criteria may be different. Intervention, the dose of the treatment, the duration may be different. The duration of follow-up may be different. The methodology of the clinical trial, the way it has been conducted may be different. So that's why heterogeneity comes into the measured by chi-square test. It's an old method to do, and p-value less than 0.1 implies heterogeneity is present. I-square is the recent statistical tool which is used, and it should be less than 50%. So what do we mean by heterogeneity? Means our meta-analysis might not be reliable or might not be meaningful because the studies have lot of variation in the results. The studies have a lot of population. So probably our meta-analysis is not going to give us a meaningful or reliable result. So that is the meaning if heterogeneity is significant. So now let's come to some exercises. This is a hindrance because we are on a webinar, it's a virtual meeting, so I can't talk to you one-to-one, but we will do some exercise and see whether we have understood the concept of forest plot or not. Now this is a meta-analysis for oncologists, especially radiation oncologists. It's a very seminal paper. It studies the effect of radiotherapy after mastectomy on breast cancer survivor. So basically in this meta-analysis, so this is the forest plot. So I have just taken out the forest plot and let's see what are the various components of this plot. So first we need to see the study label. So study label is very important. This tells us what we are examining. We are trying to examine the risk of recurrence, first recurrence in the first 9 years. Then comes the category descriptors. So what are the categories? Basically here we are trying to divide a patient into some cohorts based upon their age, tumor grade, tumor size, whether radiation, if given or not given, what is the influence of radiation with these factors. Okay, so these are the study descriptors. This basically, as I already told you, number of events, and in this case the events is the recurrence basically upon the total number of women, and this is the rate ratio. Here they have calculated the rate ratio, extreme right corner, as I told you, which gives forest plot in the numbers. And this basically the vertical line, we have seen the vertical axis is the line of no effect or line of null effect. This horizontal axis, which I told you initially, gives us the statistic of what the studies are talking about. So if you're on the left side, RT is better. If you're on the right side, RT is worse as far as this meta-analysis is concerned. Extreme left, global heterogeneity. Heterogeneity is by chi-square test and it is more than 0.1. That is, heterogeneity is not present in this meta-analysis, which is a good thing. In the study population, the study results are homogeneous and they are not conflicting. Okay, these are the results. Now what I will do, I will take out these two parts, tumor size and any systemic therapy, and I will let's analyze the forest plot in these because it's a very big forest plot. So I will take just these two for simplification. Now just spend few seconds and you see here, I will talk about these lozenges and wings again. So this is basically tumor size, and here are the studies. These are the studies. So we have 3 studies and their combined results. Okay. So if you see, concentrate on this first study. Now what does this first study tells us? Now as far as the weight of the study is concerned, yes, it's a relatively large group because the width is quite significant as compared to the last one. So it's a relatively large study, very narrow confidence interval. Again, it's the precision is there and entirely to the left side. This is the line of null effect. So since it is on the left side of line of null effect, that means whatever the intervention, in this case radiation, the intervention works. So the results are significant with intervention. Now coming to the second study, larger study group. Now you see here the width is more of this rectangle here. So it's a larger study group. Narrow confidence interval. Yes, interval confidence interval is very narrow here, but it is touching the line of null effect. So since it is crossing the line of null effect, that means the intervention doesn't work in this study, and we are quite precise that this intervention is not working in this trial. Okay, as it is crossing the midline. And why we are precise? Because the confidence interval is narrow here. Now coming to the third study, it's a small study group. The width is not much, and you see the number of patients. Only 35 patients here in the intervention, 31 in the control arm, and see the number of patients in the above two. Okay, so this you can always, once you see this plot, you can get an inference other than going into the data. Very wide confidence interval. It is also crossing the midline. That means we are unable to say if the intervention worked, because this is crossing the midline with very poor precision, as confidence interval are so wide. That means we can't comment on the effect of the treatment if we see this particular slide, this particular study. Now coming to the second one, it compares the effect of systemic therapy along with radiation in post-mastectomy patient. Let's see the first study again. Okay, it's probably a small study group. The width is not that much. With a wide confidence interval, it is crossing the line of null effect. Okay, now you use the second one, very wide. That means large number of patients, and you can compare the number of patients here. The narrow confidence interval, that, and it's entirely to the left side, that the intervention works. And if you see the diamond, this is the diamond, unfilled diamond of these two studies. That shows the intervention works because it's the left side and it is not touching the line of no effect. Okay. So this, now what I'm showing here is the pooled estimate. What I showed you is the two I took it, but if you see the entire club them together, so this diamond is showing the pooled estimate of all the studies. And this is ascending dotted line from the point estimate, which shows radiotherapy, irrespective of the grade size of the tumor in post-mastectomy settings, gives us recurrence-free survival benefit. Okay. And this is the confidence interval, again very narrow for the diamond, you can see here. Coming to the second exercise, now this basically is a meta-analysis of different types of radiotherapy in head and neck cancer. I'm not going into detail because most of you probably are not radiation oncologists. Basically what we are comparing here is standard form of radiation and modified forms of radiation. So modified forms of radiation are A, B and C. So there are different number of studies done for A type, done for B protocol and done for C protocol. And we have individual meta-analysis and a pooled estimate of these entire trials taken together. So if you see here, if you see individually, now this diamond in the A protocol, that is hyperfractionation, is on the left side, not touching the line of null effect. That means it is showing survival benefit. Now here what we are talking about is hazard ratio of death. Okay, so it is showing survival benefit, significant survival benefit, because it is not touching the line of null effect. If you see the B or C, they have a trend towards the survival benefit, but it is not statistically significant as they are touching the line of null effect. Okay, so what this shows A gives us the best survival benefit as compared to standard form of radiation. But if you see overall, if you take all the studies together, the filled diamond tells us any modified form is better than the standard form of radiotherapy. Okay, any in head and neck cancer, in some head and neck cancer. So we are not going into detail what type of meta-analysis this is. So all studies combined together, there is a benefit of modified form of radiotherapy as compared to the form of radiotherapy. So this we have got the inference from studying the forest plot. Let's see what the results actually say. So what we have gained here is A, hyperfractionation has significant survival benefit. All taken together also shows benefit. The maximum benefit is with A part, that is hyperfractionation. Now if we see the F's and the heterogeneity test shows it is less than 0.1. That means the population is heterogeneous. And yes, the population is heterogeneous because all the trials have different type of population. Population is same, but the protocol of treatment is different. So that's why heterogeneity is expected here. Now these are the results of this study. Now you see the findings. There is a benefit for modified form of radiotherapy. Maximum benefit was seen with A type, that is hyperfractionation. That means only by looking at this plot, we can get information from now on, and no need to just jump to the conclusion to read what the meta-analysis says. I hope things will be clear, a bit clear now. Now, third exercise, no, I'm not going too much into detail, but if this basically logo is a famous logo of Cochrane Group. Cochrane Group basically is a non-profit organization which does the meta-analysis in different fields, including oncology. Now, their logo has a forest plot. So anybody knows what this forest plot about? This forest plot was the first meta-analysis done by the group in 1991. It was for the patients, it was basically for the ladies who are going to have premature delivery, and giving steroids reduces the risk of complications. So this forest plot basically is the logo in each and every Cochrane meta-analysis. One more plot I will like to talk to you is that basically the funnel plot. A funnel plot basically is in the form of inverted funnel or Christmas tree. It helps us to see whether any publication bias is present in the meta-analysis. Publication bias, as I told you initially, sometimes we tend to ignore the negative result, negative studies. So for a particular question, if the study results are negative, we don't consider it. So that is a publication bias. It should not happen. Now, ideally the funnel plot should look like this, like a Christmas tree, and extreme left corner are the negative studies. If you see here, these are the left corner of whatever the studies you are showing here are the negative studies here. So if in a funnel plot you don't find, if it's not a Christmas tree pattern, if it is asymmetrical or skewed, that means the negative studies are not here and there is a publication bias in this meta-analysis, and we should not take, and we should take this meta-analysis as a pinch of salt if the funnel plot is skewed. So just to summarize my presentation, again, first column, if you remember, that shows authors or the study name. The square indicates the whatever the statistic is, RR or OR of the individual studies. Size of the square basically tells us about the weight or the power of the each trial. Horizontal lines basically are confidence interval. Vertical line is line of null effect. Diamond is overall treatment effect. Center of the diamond is combined treatment effect or combined estimate. Tip of the diamond basically is the 95% confidence interval. Diamond on the left of the line of no effect means less episodes of outcome of interest in the treatment. And mind you, the outcome can be negative, that is mortality. Outcome can be positive, that means, for example, induction of remission. So we need to be very careful what outcomes we are considering. Diamond on the right side basically shows more episodes of outcome in the treatment group. Diamond touching the line of null effect, it's not statistically significant. Diamond not touching the line of null effect means the results are statistically significant. So with this, I would like to end my presentation. Thank you all of you for patient hearing. Any questions, I would be happy to answer.
So that was an absolutely excellent talk, Dr. Kakkar. I myself am so much wiser. I never realized that one small little diamond can mean so many things, and a dotted line can mean so many things, and so on and so forth. We do have quite a number of questions, and like somebody's asked, what is the meaning of the dotted line, and what does the straight line mean, and what is a diamond? But I think you've already very comprehensively answered any of all these things. Unless you just want to dwell on it for a minute or so again, you want to tell us what is the dotted
Basically,
line mean?
Yeah, basically, as I know, okay. See, I saw one question about what did you mean by weight? Weight basically is the power of the study. Whenever we design a clinical trial, we need to know how many patients we need to accrue to get a statistically significant results. So that's why the power of the study should be adequately powered so that our results are more precise and accurate. Okay, so that's why the weight of the study is very important for us. Now, as far as the lines are concerned, I'll try to show my presentation again. I am not okay. As far as lines are concerned, the vertical line, which is smooth, is basically a line of null effect, and the dotted line, what we see here is it goes from the overall diamond. It goes from the center of the diamond. That is basically overall point estimate. So the center of the diamond is all the studies taken together, the point estimate of all the studies. If you just drop a straight line, that is the dotted line. This doesn't have so much of meaning, but it tells you whether the results are homogeneous, how the results are varying across different studies. So you can see here in this population, the heterogeneity was not there. So the dotted line basically is passing very close to most of the studies. So the dotted line basically is the overall estimate, and you drop a straight line from that. So this basically is dotted line, which has not much of a significance.
Okay, thank you so much, Dr. Kakkar. I think we are absolutely mesmerized by your talk. It was absolutely excellent, if I can say that
Thank
again.
you, ma'am. Thank you so much.
Thank you so much. And incidentally, all of this will be available on the AOGN website. And Lata, would you like to introduce Dr. Anand Narayan now, our next speaker, please?
Yeah. So, Dr. Anand Narayan is a consultant radiation oncologist. He is my colleague working at GKNM Hospital, Coimbatore. Apart from his varied interests, he also heads our in-house research methodology teaching program for all our postgraduates. Dr. Anand will speak to us on survival curves. What do they tell?
Okay. Dr. Lata, am I audible?
Yeah, you're audible, Anand.
Thank you for the introduction. So the next topic will be survival curves. And I will be just dealing with when to use these curves, how to interpret, and how do we apply this for our clinical practice. So too much of statistics today. It's been 55 minutes now. So I'll be very gentle on these curves. So this is a type, this is just an hypothetical study. What you see in the x-axis below is, one second. What you see in the x-axis below is the duration of the study. For example, this study is going to be done over 5 years. We are going to accrue patients over 5 years and follow them up for another 3 years. So the total duration of the study is going to be 8 years. Okay. So what happens in a reality study, in a practical study is, we take a patient, this is patient A, we recruited him on the day 1 of the starting of study. We followed him for 6 years and he passed away after 6 years. And this is another patient. We got this patient at 2 years after starting the study and he died after another 2 years. That is 4 years. And this is another patient who died at 4 years. So now, how do we explain this data? So this is again a continuous variable, right? 2 years, 4 years, 6 years are continuous variables. How do we explain this data? We can explain it in a very simple terms of average. That is, we can say either a mean survival, that is 6 plus 2 plus 4 divided by 3, which is 4 years. That will be an average survival with a standard deviation of 2. Or we can say the median survival of 4 years with a range of 2 to 6, right? This is fairly simple. But this is not what happens in a real study. What happens in a real study is, we get patients like this. We recruited a patient. We followed him for 8 years. He never, he was alive. He did not experience the event at the end of the study. Or the next patient, so the patient E, who was alive after 5 years. Or we have another scenario where we recruited a patient and we followed him up for 4.5 years, this line, and he lost to follow up, or he switched, he voluntarily exited out of the study, or he was lost to follow up. So now the problem is these 3 patients, we don't know when they actually expired. So they could have expired the next day, or they could have continued to live for another 10 years or 15 years. We don't know what happened to them. So now how do we explain this data? So here is the problem. So now we cannot say average, right? We have not followed them up completely till the event occurred. So we cannot give them, explain these data as an average or a median. So one way of explaining this is, assume that all these patients were recruited on day 1 and we report the survival at a particular time. For example, I just pulled all the curves to day 0. This is just a reciprocation. This is a different way of writing these lines. So I have put all the lines starting at day 0 and I reported 4 years. Now I've reported 4 years, like 83% survived at 4 years. That is 5 out of 6 patients survived at 4 years. Or 50% survived at 5 years. That is half of them. Now the problem here is, to report this, all the participants should have to be followed up to the time point. If I am reporting at 5 years, we should have followed up all the patients at 5 years, which usually cannot be done in studies practically. And also this type of reporting ignores the time of event before or after the report. So for example, if I report at 4 years, the patient who has died at 3 years or at 1 year, it doesn't make a difference. It ignores that fact. And also it also ignores whether the patient died at 6 years or 16 years, right? So there is no difference between a patient who died at 6 years versus 16 years or 3 years versus 2 years. So this is the problem. To combat this problem, we have something called as a Kaplan-Meier survival curve. So this is basically called a survival curve, but a time to event curve is a better term because it can help us beyond survival. So it can be used for any event calculation, where we need to actually quantify the time to the occurrence of event. We want to know when the event occurred. Okay, that's one point. And when where the event can be defined clearly. See, this is very important. If we calculate a Kaplan-Meier curve, the event has to be defined clearly prior to the study. We will come to the next slide. Will tell you what an event is, and where all the participants may or may not experience the event. So this is a place where we use Kaplan-Meier curve. We actually don't need to know how to create a plot because the statistical software will do it for us. But what we need to know is when to use it and what the curve means. So these are the terminologies. So the first is an event. The event is nothing but an outcome of interest. So it has to be well defined and it has to be unequivocal before we start the study. For example, if you are calculating survival, then death is an event. If you are calculating the hospital stay, that is the duration of hospital stay after a particular surgery, then discharge will be the event. Okay, is that clear? Then we go to the next term called censoring. So censoring is often a confused term. So it's very clear, very easy. The censored are those patients which we saw in that illustration where we drew an X. So those patients who did not experience the event by the end of the study are those patients whom we lost to follow up, or those patients who quit the study. So these patients were called, will be called censored. And again, there are some terminologies like median time to event, rate of event, which I will show in the subsequent slides, and the number at risk, and effect size. And as usual, no statistical analysis ends without something called as a p-value. So we have a p-value and effect size in this curves, and these two will be used when we compare two or more study arms. So this is just a this is a curve for an illustrative purposes, not a published curve. So what we see, first thing, what we are going to see is an event. So what is an event? The vertical lines you see, right? So these vertical drops you see, these are the events. So wherever there is a vertical drop, that means at that point of time, the event occurred. For example, if you see this drop occurs at around 475 days. That means at 475 days after the participant entered the study, this patient died. And this is another patient who died at around 500 days, 520 days or something like that. So these are the events. What is censoring? You see, whenever the patient is censored, that means we don't know when the event will occur. The line becomes a flat line, and there will be some vertical dashes along the flat line, and that is called censoring. So censoring is nothing but these dashes are the patients which either lost to follow up, or those are the patients who did not experience the event by the end of the study period. So this is a patient who was censored at around 300 days. And what is the median survival? Median survival is very easy. Median is nothing but 50%. So whenever you draw a horizontal line along the 50th percent of the vertical line, that is the y-axis, and you draw a perpendicular line where it meets the plotted curve. So that gives us a median survival. That is here, the median survival is around 550 days. Now, time to survival, time of the proportion of survival at particular. Sometimes we see studies reporting, survival at 2 years, survival at 3 years. So here, if we want to calculate the survival at 200 days. So you draw a perpendicular line, see where it meets our curve, and draw a horizontal line where it cuts the y-axis. So here, if you want to see the survival probability at 200 days, is nothing but 75%, right? So the 200 days survival is 75%. Similarly, a 400-day survival would be around 62%. Okay, now coming to the tricky part, that's called a number at risk. You see something below, this is the number at risk. Okay, so you say the 200-day survival is around 75%. This does not mean that all our patients survived. 75% of the patients survived at 200 days. You see a lot of vertical dashes here. That means a lot of patients are lost to follow up. And these are the patients whom we don't know when the event will occur. So this is reflected in the number at risk. You see the bottom of the curve, there will be a number at risk. So the 142 patient number denotes that at day 0, there were 142 patients in the study. That is, the study started with 142 patients. At 200th day, there were only 35 patients. That is only 25% of the total recruited patients were followed up till 200th day. So nearly 107 patients either experienced the event, that is they died, or they were lost to follow. Okay, so this again is very important, because a subsequent interpretation of this curve, say at a median survival at 550, this 550 days of median survival, we are arriving based on just around 10 patients. So this is very important, where we are drawing the line and how we are interpreting the curve. Okay, so that's why it is called as a Kaplan-Meier estimate, rather than even in the y-axis you see the survival probability. It is just a probability or estimate, because this is not the actual survival, but an estimation of survival, because these are the patients whom we don't know where they died or what are their survival are. Is that clear? Okay. So now we are going to the comparing the curves. This usually our studies have a arm A and arm B, and there will be two curves, the control arm curve and the study arm curve. So now how to compare these curves? This is the classical curve you will see in any paper. So this is what we studied, the median survival, right? The median survival of this curve is around 24 months for the control arm, whereas the median survival has not reached for the arm A or the study arm. This is how we interpret the median survival. When we want to study the 24 months survival, that is the survival at 2 years, we can say 50% of the people were surviving at 2 years in the control arm, whereas around 62% of them are surviving at the study arm, right? Now, we also see some, sentences here and numbers here. It says 2-year PFS was 50% and a 2-year PFS was 62% in the control arm. This is what we saw. And there is something called hazard ratio. The hazard ratio was explained by the previous speakers. Here the hazard ratio is 0.69. That means the hazard of experiencing the event in a study arm is 31%. That is 100 minus 69. That is 31% lesser if you enroll in a study arm compared to the control arm, right? So if you take a study drug, your chance of having an hazard, that is a progression here, is 31% lesser. This is what a hazard ratio means. And what is the confidence interval? Again, explained already. The confidence interval is 0.53 to 0.89, which means this is just one study, and our study shows a hazard ratio of 0.69. But if we were to continue the study for 100 times, 95% of the times our hazard ratio will be somewhere between 0.53 and 0.89, and this is the true hazard of taking the study drug compared to a control arm, right? And this hazard ratio and p-values are calculated using various statistical tests like log rank test, Breslow-Wilcoxon test. I will not go into the detail of that. And there will be a p-value. And as usual, if the p-value is less than 0.05, it means there's a significant difference between the two arms. And you can see in the bottom, the number at risk. You can see how many patients were recruited in the each arm. Like the control arm and the study arm, there were 268 patients at the start. And at 6 months, there are 233 patients in the study arm, whereas 216 patients in the control arm at risk. That means the rest of the patients were either experienced the event or they were lost to follow up. So this again says that how many patients were followed up till 24 months. That is, this is where the authors reported a 2-year PFS of 50%. The point where we studied the 2-year progression-free survival, there were around 110 patients or 96 patients respectively. So again, so the same curve can be interpreted in three different ways. One is a hazard ratio that we saw that the authors gave. The other is a median survival where we draw a line at 50%. So we say that the 50% survival was 24 months in the control arm, whereas it is not reached in the arm A or the study arm. Or we can also calculate the survival, survival at a particular time point. For example, we can report a 2-year survival or a 1-year survival. If it's a 1-year survival, it will be around somewhere here. Okay, 1-year survival of a control arm will be around 62%, whereas a study arm it will be around 74%. So similarly, the authors reported a 2-year survival, which is around 62% or a 50% respectively. Now, so this is what we all infer. So we can say the median survival, we can say the survival at a particular point, or we can see the hazard ratio with a confidence interval and a p-value. Now we will go to some published curves and see how we can interpret these curves. So this is a published curve. Okay. These are the survival between a HPV positive patient and a HPV negative patient in a head and neck cancer. And the top curve, the green curve, is a HPV positive patient who have a better prognosis than a HPV negative, that is a blue curve. Now you see the first 12 months, you know, the curves are hugging each other, right? That means there are certain patients who don't benefit, whether being a HPV positive or a HPV negative. Okay. And then at around 12 months, the curve starts separating. And after that, you see there is a plateau in the HPV positive group, whereas there is a HPV negative group continues to fall down. So these plateau signifies that there are some proportion of patients who are going to have a lasting benefit because they are HPV positive. And we need to follow them up longer. And if we follow them up longer, probably these patients will have a better cure rate. So this is how we interpret these curves. And the next, our job is to find who are these patients who are not responding, and we find some molecular marker or some therapy for these patients so that we divide these curves. And this is another curve. Okay. So we said we all talk about p-values, right? So here is a curve which, you know, it says there's a clear separation between these two curves, but you see the p-value. The hazard ratio is 0.98 with the confidence interval crossing unity. That's what we see. When the confidence interval crosses 1 to the either side, the confidence interval lies to the either side of the 1. That means we say that there is no absolute benefit. So the p-value is 0.42. So, you know, it looks like a benefit in the curve, but actually the statistical analysis showed that there is no benefit. So is it enough if we look at the p-value in the confidence interval? Probably not. See this curve. So here the black line represents the study arm, whereas the gray line represents the control arm. So what happened in this study was, in the initial part of the study, we see that actually those patients who were given the test drug did worse. Okay, the control arm did better. Here the hazard ratio was greater than 1. And eventually after around 6 months, the curve started separating on the other side and the study drug started showing benefit. Now the authors reported something called as a hazard ratio of 0.74, which cannot be obviously right? Here the hazard ratio alone doesn't give you any information. It shows that the study arm is 26% better, but obviously it is not in the initial part of the study, right? So hazard ratio, confidence interval, and p-value alone cannot adequately explain the curve. It is essential that we visually see the curve itself and interpret the visual interpretation of the curve also becomes an important. And okay, so is the visual interpretation and p-value enough? It's again a sample curve. You see these two curves are really tight, right? But you see the authors, what is the conclusion of the study? P-value is less than 0.001. It's really a significant p-value. So they did a zoom of this curve and they showed that, you know, this is a cardiology study. And here they showed that the ticagrelor is a study arm and clopidogrel is a control arm. They showed that the curves are separating. Now what? At 6 months, if you see the absolute benefit, you know that at 6 months, what is the proportion of patients who experience the event in the study, in the control arm? It is around 9.2% or something. And in the study arm, it is around 7.8%. So actually, the benefit is around 1.2%. But what happened is, because you see here, but what happened is, since the events are very less, this 1.2% absolute benefit translated into a 16% relative benefit with a 95% confidence interval of 0.7595, one side of unity, resulting in a p-value of less than 0.01. But we also have to look at the number at risk. See how many patients they studied. They studied around 9,500 patients in each arm, which is around 19,000 patients they studied to arrive at a conclusion that this ticagrelor is better than clopidogrel. So now, is this a statistically benefit? Is there a statistically benefit? Obviously, yes. P-value is less than 1. The curves are diverging from each other. Confidence interval is one side of the unity. Everything shows a statistical benefit. But is there a clinical benefit? That is something which we have to decide as clinicians. So it will depend upon multiple factors, that like the number needed to treat. Here we have to treat, because it's another concept. I will not go into the concept of NNT. You can just look up in Wikipedia or any Google. So here the number needed to treat will be 84. That means we have to treat 84 people to save one person from the endpoint. So is this okay for us? What is the cost of this new drug? What will be the resource utilization of this new therapy if it's going to be some technique or surgery? What will be the toxicity of the new drug? So all this will decide whether this statistical significance is a clinical significant or not. So coming to the conclusion, the survival curve is a very simple, but it's a very powerful way to express multiple information. It can give you survival at a particular point, median survival, survival events at every point of time, what is the difference between the two arms, whether it is statistically significant or not. So it gives a multiple information, but it is just not p-value. We have to look beyond p-value because we are used to look at p-value and say that is significant. For a proper interpretation of the data, I showed you multiple examples. And as clinicians, we also have to correlate the statistical effects using a visual analysis, hazard ratio, confidence interval, and correlate with the clinical significance. What is the cost of the new therapy, resource consumption, and toxicity to translate this data into a clinical practice. Thank you, everyone. I hope I was clear, and I would be happy to take questions and comments.
Thank you, Dr. Anand. That was a wonderful, wonderful presentation, very succinct and to the point. There are a couple of questions that have been sent privately, but we are running quite late and I don't want the session to be cut short. So I will request all this, I will send all the questions to the speakers. Maybe you can do a voice recording and send it. I just want to thank all delegates for joining us and to let them know that all these will be recorded and placed on the AOGIN website by Wednesday next week. Please join us again next Saturday. The topic is how to read a paper and incorporate it in our clinical practice, which I think all of us will benefit from. We have an excellent speaker, Dr. Shantam Chakrabarti from Tata Medical Center, Kolkata. So looking forward to seeing all of you next Saturday. Have a very good evening. Thank you, speakers. Thank you, chairpersons.
Thank you so much. That was an absolutely fantastic session. Thanks a lot.
Thank you.
Excellent speakers.